Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, and comments that you wish to share with the audience can be typed into the chat box, visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweet or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community, our province, and the country. Today, we're delighted to partner with the Canadian Premature Babies Foundation to bring you Parental Presence in the NICUs across Canada, Restrictions, Evidence, and Recommendations. I'd like to introduce our speakers for today. Fabiana Baccini is the Executive Director of the Canadian Premature Babies Foundation. She's a journalist and a published author of From Surviving to Thriving, A Mother's Journey Through Infertility, Loss, and Miracles. While in the NICU with her surviving twin, born extremely preterm, she participated in the study of family integrated care, or FICare, a model that changes how we deliver care to families and their infants in the NICU. This led her to extensive volunteering in the NICU at Mount Sinai Hospital and to become an ambassador for FICare across Canada and internationally. Dr. Marcia Campbell-Yeo is a neonatal nurse practitioner, clinical scientist, and full professor at the School of Nursing, Faculty of Health at Dalhousie University. Marcia holds cross appointments in the departments of pediatrics and psychology and neuroscience. And Dr. Carol O'Brien is a staff neonatologist at Mount Sinai Hospital, associate professor of pediatrics at the University of Toronto, and a clinical teacher and neonatologist at the very busy perinatal center that specializes in fetal diagnosis and therapy, and also works in a follow-up clinic. Carol's current research is focused on the development of the FICare model, and she has recently completed an international trial of this model. Just a reminder that we record all our webinars. As mentioned in the introductory video, please type your questions into the question box at any time, and I'll prompt you via the chat as well. And we'll have our Q&A period at the end of the session. It's now my pleasure to pass the mic to Fabiana.
Hello, everyone. Thank you, Paula, for the introduction. I also want to thank the Children's Healthcare Canada for having us here today, and thank each and every one of you for taking the time to engage in this important conversation. So I'm going to share my screen here. Give me 1 second. Here we are. So we have no financial or conflict of interest. And as Paula mentioned, we're going to talk about parental presence in the NICUs across Canada. We'll discuss restrictions, evidence, and recommendations. For years, NICUs around the world strived to implement family-centered care. And in more recent years, the family integrated care, as known as FICare model, gave parents a bigger role in the NICU, where they were seen as part of the team. Parent partners were inside the NICUs providing support for families and advising the NICU teams, working on a real collaboration in many units across our country and in many other countries. There is no lack of evidence showing that parental involvement in the care of their baby in the NICU have many benefits for the babies, such as better neurodevelopmental outcomes, increased breastfeeding rates, less retinopathy of prematurity. We also know when parents read and sing for their babies, they develop language earlier in life. There is also evidence showing decreasing parental stress and anxiety, improved behavior outcomes, and parents have become more empowered and better advocates for their child after discharge. And I can certainly testify to that. I spent over 1,200 hours by my son's bedside when he was in the NICU. My husband and I had unlimited access. Not only were part of his care, but we also part of the team. We were there around, making informed decisions, which help us to become better parents and his advocate in the community. When you bring a preemie baby home as a parent, you have to have the confidence in a different skill set to care for that child. And this is what being engaged in his care really did for me. It prepared me for the very long road ahead. So this picture was taken in 2016 when we just finished the FICare conference and training in Banff, and where the results of the international FICare research was presented. This information showed that the neonatal community had reached a point of no return. There was no looking back. There was only looking forward, integrating parents to the care of their infants in decision-making, access to the NICU 24/7, parents presenting around, music and reading programs, peer-to-peer support groups, parental partners by the bedside, and programs for siblings. We still had ways to go, but we had made so much progress. So one of the main finds of FICare research identified the immense value of peer-to-peer support and parent partners. And in 2018, the medical community, in collaboration with CPBF, invited 18 parents from across Canada to participate with a national group of researchers with the Canadian Neonatal Network. This was the first time that all stakeholders were at this table. But then March 2020, and the world stopped, and the hospitals immediately did what they needed to do: protect their patients and staff against an invisible enemy that we knew so little about. Hospitals applied a one-size-fits-all approach to visiting without any regard to different patient areas. Much of the focus was on adult care, and the essential and irreplaceable benefits of parental caregiving was not considered separately. Parent advisors were not consulted around hospital policies in general, which made many believe that the engagement had been artificial and that they were treated with tokenism all along. Sadly, parents were immediately seen as visitors, not as partners in care or essential caregivers. In some units in Canada, parents had visiting hours. Others had one parent at a time on a 24-hour period. Parents couldn't come and go. Parents couldn't cross the provincial borders. Restrictions in parent involvement also extended to palliative care and critically ill infants. Possibly the assumption was that the parents were more likely to become infected in the community than the staff. And some even said that they feared if parents were unwell, they would still continue to come and stay with their baby. Those were huge assumptions. In fact, the questions you should be asking were, can we educate parents as partners in care? Why couldn't they not be screened and protected just like the healthcare professionals? Knowing that parents are essential caregivers in the NICU, should we have asked instead how to teach them to stay safe, and how can we screen and protect them just as you do with the staff? So families have been sharing stories from the beginning of the pandemic through our social media channels and our peer support groups. They come to CPBF seeking peer support or any kind of help and really looking for a listening shoulder. They are desperate. As a mother who spent 5 months in the NICU, I cannot even imagine what it is to go through that emotional roller coaster alone. And here I have some quotes that parents have shared with us. I just chose a few. There's so many that they felt, they felt robbed. Oh, I can't go back here. They feel robbed of the experience of being together as a complete family. I still have flashbacks almost 9 months later, being alone, especially when my son had serious complications. Some memories still bring me to tears. And those are just a few quotes that we have received. We have received hundreds of stories from the beginning. So through this horrific experience and impact on parents, the International FICare Committee, in collaboration with CPBF, created a position statement on parents as essential caregivers in the NICU with recommendations for best practices last summer. The goal of the position statement was to provide guidance to NICUs about how to keep parents and their babies together safely. And part of this position statement became a publication that Dr. Carol Bryan will share in just a few minutes. We have also joined the International Zero Separation Campaign to increase awareness regarding zero separation of infants and parents, which is extremely important, and we're still dealing with a pandemic. You can join the conversation on our social media channels as we continue to advocate for parents to be included in the care of their own babies. So now I'm going to pass to Dr. Marcia Campoyo to continue this presentation. Just bear with me 1 second.
We're just switching slide decks. Give us a moment.
While we do that, I will just thank Fabiana and Children's Healthcare Canada for the invitation to share with you our findings today on the impact of parental presence restrictions on Canadian families in the NICU during COVID-19 and the results of our preliminary national survey. If you can change, Fabiana. So we know that, as Fabiana just told us, that there was really a hard stop in the having families as part of care in the NICU, and they really were relegated immediately to visitor status from what they had been previously as essential caregivers in the NICU. Next slide, Fabiana. So even our health center in the IWK Health in Nova Scotia, which has such a strong family integrated philosophy, we at our strictest times, we only allowed one support person in the NICU. Families had partners, many partners had to leave very shortly after the birth and could not return to the hospital. We even had many families had to choose between children at home, homeschooling, lack of daycares. So this meant that many babies, up to 20 to 25%, were actually alone in the NICU. Thankfully, due to our epidemiology, we have seen a reduction with now 2 care providers, but we still see a reduction in sibling presence or extended families. And so we knew that this was happening with us, but we also knew that there was many variations across the country, and we really had no understanding of what the impact was in the Canadian context. And so because of this, next slide, please, Fabiana, through funding of a local COVID-19 grant, we were able to co-create with clinicians, parents and researchers and national parent survey with the aim to really understand from a Canadian parent perspective the impact of parental presence restrictions in response to COVID-19, about the potential variation in practices and policies across the country, and to identify potential gaps and opportunities to improve care for infants and families. And so what did the survey look like? Well, it really encompassed 8 primary areas, looking at the specific NICU that the family was admitted to, demographic information, information on the parental perception of the policy and their ability to move about in the hospital. We used situational Likert scale questions to ask questions around the stress and impact, use of technology, COVID exposure, and we also embedded 8 qualitative open-ended questions if families wanted to provide additional information. So we circulated the survey through a secure REDCap link, and any family who had a baby admitted to a neonatal intensive care unit after March 1st, 2020 was able to participate, and it was open between November 2020 and February 2021. We recruited primarily through social media, NICU forums, and emails through stakeholders. And so what did we find? Well, what we found was we had 233 respondents, and we were very happy to see that there was quite a good representation from all provinces as well as Nunavut. And of course, you can see on the x-axis the percent. The larger provinces, as expected, had the higher percent responses and lower responses from the smaller provinces, but a good representation. So then what did the respondents look like? Well, they were actually quite generalizable to what we'd expect from NICU parents. So the infants were primarily about 60 to 65% were male. The majority were singletons. There was a good range of either very low birth weight babies, late preterm, or term infants with an average length of stay about a month in the NICU. And we saw that distance from hospital ranged from very close by to up to 5 hours drive, with the majority being generally within close by or within the city limits. So what about the respondents themselves? Well, the most of them were mothers. We did invite both parents to participate, but majority were mothers. 31 years old was the average age, most identified as being white. The majority had some form of post-secondary education, and the majority had English was the primary language spoken at home. The majority referred them to themselves as being in a relationship, and we saw a range of economic status from less than $25,000 a year for annual household income to over $200,000, but the majority ranged between about $50,000 and $200,000 per year. So we also, to help us try to understand the data, we also looked a little bit we broke it down into 2 cohorts. What we considered the less restrictive cohorts, in which there was still ability to have 2 providers, which was in yellow, about 31% of our respondents, and those who had quite severe restrictions of either not being allowed at all in the NICU or only 1 support person, which was about 69%. So then what we did was we superimposed these low versus high restrictions once again on our provincial respondents, and we can see that there are significant variations both across provinces but also within provinces, and you'll find even within the same city. So then what happened was we wanted to ask families what their perception was of the parent policy. And so again, we see the low cohort in the yellow and the high cohort in the blue. And we see that for the most part, the majority, up to about 70% of the families were sent home at night. They were from anywhere from about 25 to 35% were able to have some other family member to be able to come and go with them in to see the baby. We see that very few units actually tested families prior to admission, but most screened families prior to entrance to the NICU. And there was some switching out of who the support person was, with up to 60% in the high restrictive groups being able to do so. So next we asked, we wanted to know what the restrictions were and how they impacted the support person's personal needs. And we see that their movements in the hospital. And we see that there was very little difference between the cohorts, with the majority of participants being provided a mask or sanitizer when they entered the NICU. And interestingly, the majority were able to actually leave the NICU and return to go outside, to exercise if they felt overwhelmed. But we see about 30% of the families were not able to leave the hospital at any time, or if so they did, they could not return. So next we wanted to see about the impact on the support person's personal needs, and we see about 20% of families had a difficult time finding toilet or shower facilities. Most were offered a place to sleep in the hospital, and less than about 25% were able to eat, however, at the baby's bedside in the NICU. I think quite alarmingly, we saw that about 55% of the families reported being hungry and not having enough to eat, and many reported difficulty in having access to dietary or cultural foods. And we see that about 20% of the hospital did provide free food to families, and only about less than 5% provided food at any type of reduced rate. So next, we asked a series of Likert scale questions in which families could report either anywhere from a 1 to 7 rating, from completely disagree on the left to completely agree on the right. And their responses are seen in the blob. So the bigger the blob, the more responses. And we can see that we see the boxes show the center one is the mean, and the upper and lower the 25 and 75th percentiles. So when we asked families about when they were with their infant in the hospital, how did the policies make them feel? And we can see that for the most part, those families in the highest restrictions areas felt that the policies were more difficult to understand. They felt less respected, more undervalued, and they had a more difficult time accessing medications or healthcare for themselves. So using a very similar type of response, next slide, please. We asked families several questions, and we had them rate, again, from completely disagree to a completely agree, across 3 types of situation contexts. Either how traumatic was it to be away from your infant, how traumatic was it to be alone, and how much they wish they had had a support person. And we asked these across 4 common events that happen in the NICU. And we can see that regardless of the cohort, that the majority of families either agreed or completely agreed that it was very traumatic to have, across any of those scenarios, to receive bad news, during daily medical rounds, when they received medical information, or when their infant was admitted. Similarly, we asked a very similar type of questions across uncommon events. Next slide, please. And these events about when their infant died, when their infant had a major procedure, when they provided consent for a procedure, or when their infant's condition worsened. And again, across the 3 contexts, the majority of respondents completely agreed that it was very traumatic to be away from their infant, traumatic to be alone, and they wished that they had had a support person with them. So next we wanted to ask and try to differentiate the stress of these parental presence policies beyond the stress of just having an infant in the NICU. So we asked families, in addition to having your baby in the NICU, can you answer how much additional stress you think that these parent restriction policies have had on you? And we can see on the scale of 0 to 10, from a no additional stress to worst possible stress, that about 60% of the respondents said that it was extremely distressing to the worst possible distress of the parent presence restriction policies. About 30% said very uncomfortable to very distressing. And about less than 10% said no additional stress or mild. And of note, these in the latter group were only those in the low restrictive cohort. So next we wanted to know about information sharing and technology. So we wanted to know how the medical team communicated with families. we can see that the majority communicated through telephone and used very little other types of digital types of resources or technology. And surprisingly, about 20 to 25% of families said they actually had no communication from healthcare providers. When we asked families how they stayed connected to either their family in the NICU or they felt to be close to their baby, majority said telephone, and a few others used video conferencing. Again, about 30% of families, especially in the high restrictive zones, had absolutely no way to have communication with their loved ones at home. Of those families who used technology, the majority felt used their own device. Majority felt the internet was of acceptable quality. They felt highly comfortable with using technology and did not require any or feel the need for any additional training for use. So next we wanted to know about the exposure that they had with COVID around their family health. And of all the participants, when we asked if they themselves had any symptoms, if they had diagnosis or any positive tests, we see that virtually 97% to 100% said no. And then we asked about any household exposure, and only one of all the recipients said that they had had a family member who was hospitalized and one death due to COVID. So next we wanted to, again, due to the time today, I just will very briefly mention our parent qualitative narratives. I was just shocked with the amount of information that these families included. These were optional, open-ended. Do you want to tell us one or two things? And it was just amazing at how much families wanted to say. So just for the time today, I'm just going to mention one or two of the quotes, but you can see in the brackets is how many families who actually responded to these questions. When we asked about their experience, one mom said the cafeteria wasn't always open. I was hungry. Another said I was in significant pain and I was unable to access pain meds. It was highly traumatic to me. When we asked about how they kept connected, we were quite surprised in the variation in these responses. So not surprisingly, one mom said video calls with my family, but one BC mom said no, we were told that Zooming with the baby was too overstimulating, so we weren't able to do it. An Ontario mom said FaceTime, but it was not really allowed, so we made quick phone calls when the nurses were not around. And an Ontario, Alberta mom said FaceTime was the best way, but we were asked many times to not be on the phone while in the NICU, so it made it very impossible. Last week, we asked about what was the hardest part about having your infant in the NICU during COVID-19, and this one dad said, I could not be with my wife after we lost a twin, and his brother still was in the NICU. This had far-reaching implications for our mental health. It was cruel and an unnecessary policy when one looks at our epidemiology. We could have easily co-hosted as a two-parent family bubble with our surviving infant. We should have been granted an exception because of the death of our son. I'll never forgive the hospital for this. And then we asked, how did the impact your family? And I think this is, one BC mom said, I lost my daughter after a month in the NICU, and no one in my family was able to meet her, to know her. I think that hurts the most. And so what are our take-home messages? Well, I think it was quite clear that the parental presence restrictions in response to COVID-19 had significant impact on families. There was considerable variation both across and within provinces, and it had high perceived impact on families. There was certainly a need to have provision or better access to food and places to eat for families, as well as access to medications and healthcare. Especially it was relevant for those families who are crossing borders. There needed to be a greater focus on breastfeeding success. And we also saw a significantly high variability in the access and use of technology. Parents' comfort and wish to use technology was perceived as high. A virtual care should be used as an adjuvant to care and not meant to replace parental presence. And parents reported wanting not to be considered as visitors, but rather seen as essential members of the team with access to PPE and vaccines. And most importantly, parents emphasized the importance of ensuring at least two support persons were always able to be in the NICU. So I would just like to, again, acknowledge some of our funders, our team, and really special thanks to the families for participating, our co-investigators. And I'm going to send it over now to Carol to really help with us, to tell us what is the current evidence that we know beyond the Canadian situation and recommendations for where we need to go next. Thank you very much.
Thank you, Marcia. And Fabiana. Fabiana's in charge of the slides here. But definitely, it's been a difficult year for families of preterm infants who would believe that this really pretty little virus would have caused such disruption in the world. And the Canadian Premature Baby Foundation has done an amazing job by supporting families with the dissemination of knowledge about family integrated care, and has partnered with our Family Integrated Care National and International Steering Committees to support the implementation and sustainability of FICare, despite the COVID pandemic. Next slide, please. So I think what I want to bring everybody back to, and I know Fabiana touched on this, but I think we need to, when we're trying to justify why parents in NICUs need to be treated differently than other people in the hospital who are considered visitors, we really need to understand the importance of parental presence for the infant and the parents in the NICU. So preterm infants have an increased risk of subtle challenges with learning, communication, moving, and behavior. And the cause of behavioral problems are multifactorial, including the effect of parent-infant interactions. Behavioral problems really specifically impact the day-to-day function of the family and kind of impact on school success, even in children with normal neurodevelopmental outcomes. Next slide, please. So what we also know about family integrated care is that when parents are involved in the care of their infants in the neonatal intensive care, that there are better infant medical outcomes. We know that actually parental presence causes improved infant weight gain, decreased nosocomial infection, decreased parent stress and anxiety, reduction of readmission to hospital, and improved breastfeeding. And this is from our cluster randomized control, international cluster randomized control trial, but also from other studies across the world. Next slide, please. We also know that parent-infant interaction shapes the development of the infant, and that parent engagement in care, particularly during painful procedures, can actually protect brain development. Following discharge, sorry, Fabiana, I wasn't finished. Attuned parents provide developmentally responsive care, which impacts the infant's nervous system and furthers normal brain development. I think a reminder for people who are on the call who may not be neonatologists or even pediatricians is that infant brain growth from 35 weeks to 40 weeks is dramatic in the NICU. And that infant brain growth is seriously impacted by parental presence. Next slide, please. Also, family integrated care, we now have shown, has a sustained effect on child behavior. We did a follow-up study of babies who were enrolled in the FICare cluster randomized controlled trial. And we were able to demonstrate that infants who were in FICare had better self-regulation than those who were in control sites. And parental stress was actually a mediator of the impact of family integrated care on child behavior. So what that means is that parents who were with their baby in the NICU, who participated in care, were able to engage better with their infant following discharge, had less stress in taking care of their infant, and their infant's behavior was better, even when we saw them at 18 to 21 months corrected age. Next slide, please. We also know that when parents are engaged in the care of their infant in the NICU, that parents, their outcome is better. Parents can suffer because of stress and separation from their infant. There are multiple traumas from an NICU stay, and parents in the NICU are known to be at increased risk of depression and anxiety, and these can be mitigated by actually having parents engaged in care. And the parent's emotional state during and after the NICU stay will impact their ability to respond to their infant's cues and the long-term health of the family unit. Next slide, please. This again is just reminding us of what Fabiana started with. So what happened with COVID? Here were all these hospitals that were saying they were family-centered and had parents on committees and parents engaged in decision-making. And yet when COVID started, the fear of spread in the NICUs and infection in staff meant that we actually did not engage families in this decision-making at all. We went back to our old way of doing things. Instead of embracing families in decision-making about how to protect their infant and staff, we responded out of fear. Infection control became the primary objective during the first wave, and often we had irrational policies around parents in the NICU. And the sharing of information with parents around that decision-making was haphazard, and policy varied from hospital to hospital. Next slide, please. Our International Family Integrated Care Steering Committee was very concerned about what was happening across the world. And Fabiana, as you can see, is a member of that committee, and she was really concerned about what she was hearing about in social media in Canada as well as throughout the world. So we came together to publish basically guidelines around, basically evidence-based guidelines around how parents could be safely engaged in their care of their infant in the NICU. However, those guidelines really did not get much attention. So therefore, we went ahead to try and publish in an international journal, again, to garner attention on these guidelines. Next slide, please. Our publication was published in Acta Pediatrica, and as you can see, it was really supporting parents as essential care partners in neonatal units during the SARS-CoV pandemic. Next slide, please. This was a systematic review of the literature, reviewing the evidence on the safety of maintaining family integrated care practices during the pandemic. We reviewed all scientific papers that were published on this, empirical research, both qualitative and quantitative or mixed methods. Any paper that reported on the effects of restricting or promoting family-centered care practices on parents or the needs of hospitalized infants. We had 2 independent reviewers from our group review the papers, and discrepancies were resolved by the research team. Next slide, please. In total, we reviewed 803 abstracts on all these databases. 75 papers were fully screened, and 7 articles were included in the systematic review. The 7 articles included data on 854 healthcare providers, 442 parents, 364 infants, and 26 other family members within 286 neonatal units. Next slide, please. As you can see, these studies came from many different sites, including some from the USA, some from the UK, some from Italy, particularly during the height of the pandemic, and some reports from China. Next slide, please. This is a list of the included studies. Next slide, please. So what did we learn in this systematic review? Well, we learned that first of all, the pandemic responses of hospitals revealed changes in, first of all, hospital entry screening. Just as Marcia said, in Canada, most sites had temperature checks and triage or screening questions. Almost all units revoked 24-hour access to the NICU, and some hospitals completely refused entry, even when a child was in extremis. Most hospitals, as you see in the chat even here today, allowed only 1 parent at a time. Most hospitals decreased access to food and to rest space for families, and almost all hospitals had decreased lactation and therapy support. I'm just going to review one. Next slide, please, Fabiana. This is just one report. This is from Darcy Mahoney et al. And this was a cross-sectional survey of 27 NICUs. Most of these NICUs were in the United States. That was a global study. 47% of the NICUs had restricted parental presence, and most only allowed a single parent to visit. And 7 sites, however, completely prohibited parents. Next slide, please. So what do we know about those fears of COVID transmission in the NICU? Was any of that borne out in the published studies? Interestingly, there were no published reports of in-hospital transmission between neonatal patients. So there was no nosocomial infection with COVID in any of the NICUs that have been reported to date. In Italy, in the Italian study, which was where they actually described in detail the presence of SARS-CoV infections during the high prevalence period of the pandemic. At that time, parents were routinely screened on arrival to the unit, and parental presence was restricted in time to one parent per time. Parents and healthcare providers were screened weekly with nasal swabs and immunoglobulin tests. However, what they demonstrated was the rate of positivity in the NICU staff and the parents was the same in the community as it was in the community, and that was 2.2% at the time. None of the admitted babies tested positive, including those who were born to COVID-19 positive mothers, and that's been borne out in further studies. Interestingly, transmission in hospital generally occurred between staff, not between parents and staff, but between staff themselves. And that really was in breakout rooms or in mask-off areas where the staff could actually not safely maintain physical distancing while eating. Next slide, please. So what do we know about the impact of COVID-19 restrictions on families? Well, first of all, we know that mothers of infants in the NICU reported not receiving enough information on expressing breast milk or receiving enough breastfeeding support in the NICU. Most mothers in the NICU actually stopped breastfeeding earlier. Interesting, that's very different than the term population, where in fact there are reports that mothers during COVID have actually been able to breastfeed for longer as they are able to spend more time at home with their infant. There was definitely, parents reported a negative impact on parent-infant bonding and parent engagement in care. Some parents reported not being able to see their baby at all, or at least for days after birth. Parents frequently reported not being supported to provide skin-to-skin care. Again, the rationale being the increased risk of COVID transmission. And parents were often not encouraged to hold their infant, again, which decreases their opportunities for bonding with their infant. Some parents reported that they needed to schedule how to manage their time with their infant. So they had to sort of say in that hour of visiting time, were they there to get an update from staff or actually spend time with their infant. There have been identified concerns for parent mental health, both from not being able to spend time with their infant and also lack of psychosocial support and psychological support, both in hospital and on discharge. In addition, there's been reported a long-term infant on maternal mental health and parent-infant interaction. Next slide, please. This perhaps is the most important thing that has impacted families, is that there's been an inconsistency about how parents and infants are treated across sites, even within the same geographic region. For those of you who are not familiar with the neonatal system, often babies are transported from hospital to hospital. They may start their course in one hospital, a level 3 NICU, and be transferred to a level 2 NICU prior to discharge home. And the policies across even the same regions were different as regards COVID policies. Every hospital formed their own policies with their own infection control staff. Interestingly, there was actually, the staff did fear and anxiety about the risk of nosocomial infection due to parental presence and lack of PPE, often made parents feel unwelcome in the NICU. There is specific concerns about parental presence in single room versus open unit design. I'm going to address that a little bit further. But in fact, these concerns were likely unfounded in that if parents are treated as important caregivers in the NICU and are treated the same as other caregivers, as in NICU staff, and are treated with the same sort of protection and PPE as other NICU staff, there's no increased risk of transmission to other staff in the NICU. I don't know if any of you had a chance to look at the paper this morning about staff dealing with stress and emotional needs of family, and how this actually, again, keeping parents out of the NICU meant that parents were more stressed and actually making more emotional demands of staff in the NICU. Next slide, please. So the guiding principle of our recommendations re parental presence in the NICU are that parents are not visitors. They are care providers, and therefore they should be treated in the same way as other care providers are. And next slide, please. These are our printed recommendations. They're available both at the Family Integrated Care website and also the CPF-BF website, as well as in the published paper. But the recommendations are that both parents should be with their infant in the neonatal unit and postnatal ward unless they're symptomatic or have been advised to self-isolate or quarantine. Parents should be involved in the infant's care without time restriction. There's absolutely no rationale for a time restriction, considering that the risk of infection does not go up with the longer the time that families spend in the unit. Parents should be provided with the same protection as other essential staff. That is a hospital-grade face mask, and in some scenarios that may actually change to being an N95 mask with a variance of concern. Parents and staff should both adhere to physical distancing policies in the neonatal unit or postnatal ward, and that requires to mask off areas and areas for eating. Next slide, please. All parents and staff should be educated and apply appropriate hand and respiratory hygiene measures within the hospital and the home environment. Where possible, there should be dedicated space for parents to eat safely and to rest. Appropriate technological support using video calling and apps should not be used to replace parental presence, but can be used to support parental involvement. And neonatal teams should make every effort to provide additional measures to support parental presence, including the provisions of face masks, accommodation, parking, and transport. Next slide, please. Again, the issue about masking is really probably something that's going to be really important in the next year. Marcia and I have actually applied for funding to look at the impact of masking on language and neurodevelopment in the infants long term. But we would argue that where a safe physical distance can be maintained between staff and families, that is in single rooms, parents could be supported to provide for the infant cot side without using a face coverings for a short duration of time. And also, we have really encouraged units to look at the use of clear face masks, as have been used in units in the UK and US, to support infant language development. Next slide, please. Again, vaccination, this is now an option for parents. And parents as primary caregivers and members of the neonatal team should be given early access to vaccination in ICUs to reduce the risk of transmission between staff and parents and vice versa. Pregnant women should also be vaccinated so that both they and their infant are protected early in pregnancy. The SOGC recommendation is that they now be vaccinated even in the first trimester. And a vaccination of breastfeeding mothers is not only safe, but advised. So again, no reason not to vaccinate parents in the NICU. So I'm going to finish just sort of saying, yes, it's been really difficult for families. It's been a terrible year with many postponed celebrations and get-togethers. But one thing I have learned as a neonatologist is that families of preterm infants and the infants themselves are amazingly resilient, and we just need to remember how important they are. Fabiana is going to outline a call for action to redress the injustice that we have imposed on families today. Thank you.
Thank you. Just give us a moment while we switch again. Almost there. Seems we're having a little bit of technical. There we go.
I'm sorry. And I just want to thank Carol and Marcia for this incredible work they've been doing over the last year. And unfortunately, despite of this evidence, restrictions are still happening in our country, as you can see from this parent story, where they're only allowed 2-3 hour blocks a day to be with the baby. Well, I think when we work together, we can really see true family integration again, which means both parents at the bedside and siblings involved. We really want to see families thriving, healthy relationships, which will improve bonding and mental health, feeding, and better discharge planning. We want to see parents and parent partners providing support for families. And I believe if you all work together, we can certainly see a better short and long-term outcomes for babies and their families. And we are here to work with you. CPBF has a lot of resources for families on our website, canadianpreemies.org. And here's our information, and we are ready to take some questions from the group. Thank you so much.
Thank you all. We do have a few questions here, so I'll just get started. One question from an anonymous attendee. What is the evidence that both parents living in the same household being present would increase the risk for the whole family unit or the NICU itself?
There is no evidence for that. I think some units introduced this initially as a way of decreasing. There was sort of a big push to decrease the number of feet on the ground. Boots on the ground was the way it was described in our NICU. So it was the idea that bringing in fewer people into the NICU would decrease the risk of transmission in the NICU. However, as you just stated, those two parents are from the same environment. And if the parents are from the same environments, there should be no increased risk of exposure. But the rationale originally was just decreasing the number of boots on the ground. That was the rationale that our infection control people put behind this. So we have really challenged that. And despite the, I would say the more serious outbreaks recently, we've been able to maintain two parents visiting at a time from the same household. So again, that's something we have challenged from the original outbreak.
And your challenges have been met with success?
Correct. Yeah.
Oh,
so now we've been able to maintain two parents at a time with the baby, as long as they're living together.
Oh, fair. And what happens in the case of potentially separated families?
So they would be considered as being two different households. So again, they're allowed to come, but separately for that reason.
Makes sense.
Yeah. So until, particularly under the provincial, it would depend on the province you're in and what the guidelines are around people gathering from different households. So in Ontario right now, you're not supposed to gather with the different households. So therefore, we wouldn't be promoting that within the NICU.
Right.
Yeah.
Another question is how can or how do you share current family-centered policies that are inclusive of parents during the pandemic across units across the country who may be imposing more restrictive policies on parental presence?
So I think we've tried different ways. Certainly, most recently, we've did this presentation through the Canadian Neonatal Network and through the EPIC or Quality Improvement programs, in which 32 NICUs across the country to try to raise awareness and share guidelines to increase awareness. And certainly, I think, Fabiana, I'll let you speak to through the Canadian Premature Baby Foundation. But I would just say that one caveat, and why, again, it's very exciting for us to be here today, is while we have worked quite closely with many of our neonatal colleagues, we recognize that a lot of these policies are made and instituted outside of the NICU. And so we also need to broaden our reach to infectious control, public health, and other people to try to ensure that all of the right people who are at those tables actually have access and are really aware of what's happening. And Fabiana, do you want to mention about this CPBF?
Sorry, I was mute. We've been doing a lot of social media campaigns to really put this information out there to everyone who is interested in learning about, especially now with the publication, and also to really understand the parents' experiences, because sometimes we think short term, just what is happening in the NICU, we don't see the long term impact of those restrictions in families. And these are the stories that are coming to us, and families are suffering. They are like really having a hard time once the baby gets discharged. And I think we really need to work together to review policies and protocols in hospitals, and how can we bring families together safely into the units.
I think one of the things that's been really difficult is to get a recognition for parents as the need for parents to be primary caregivers in the NICU, and how that's so different than what's going on in our adult ICUs right now. Remember, adults who are admitted to ICU are often being admitted because of COVID positivity, and are often coming from families where the family members are COVID positive. And that's very different than what we're dealing with in NICUs. So I think that's been part of our challenge, is making that argument clearly to our infection control colleagues that NICUs are different, and the babies who are being admitted for different reasons, and parents are really important. And it is really important to have parents present in the NICU. So making that distinction has been really important for us to be able to get any change in our policies.
Absolutely. Ultimately, it's just to understand that we are not visitors about the baby. We are really caregivers, and the parent that are going to take care of the child for the rest of their life. So if you're not present from the beginning to understand the child's needs and how can we bond and really take care of that child, how can we possibly be a good parent at home and understand the needs of that child when you're not able to be present to understand from the beginning and participate in decision making. I think that is what we want to be seen as the caregivers and not visitors.
To what extent has hospital leadership, so above the decision making that happens above the departments like NICU or infection control, are supportive of this policies like this?
So I think that's been the real challenge.
Yeah.
Initially, the challenge was to make sure that we got this issue up to hospital leadership and got them to understand, and made a case that families in the NICU were different than families in other parts of the hospital. Particularly, most perinatal centers are in adult hospitals, not in pediatric centers. So this required a lot of education of our hospital administration and a lot of lobbying to them about the difference. So I think that's been part of the challenge across Canada, is this is the first time we've often had to go to our adult administrators and and make them aware of how different we are.
Fair. Michelle asks, are hospitals also limiting staff going to primary care, for example, to also ensure fewer staff are going in and out of patient care areas, or are restrictions mostly family-based? And if they're family-based, what evidence is being cited for the policy change?
So I'm not sure, Marcia, but I can speak to Ontario, and basically there has been a limiting of staff movement between different hospital sites, between primary care and in hospitals. So yes, there definitely has been a restriction around the movement of staff. So similarly to families, there has been a restriction around the movement of staff in different areas of the hospital or between hospitals.
Thank you.
Yes, I would just make a comment. So we have, in the attempt to ensure that the family and two family members can be there, and limiting the amount of additional staff. So, for example, we have moved in Nova Scotia primarily to virtual medical rounds. So therefore, really limiting the need to have multiple people at the bedside at one time. So that the parents can be at the bedside, and then they join a virtual link, the staff and physicians join a virtual link. And in fact, we've heard very positive feedback on that, in that people then, because they're at their own offices or in a place, can actually remove masks. So you can actually have a conversation and feel even more close to build better relationships with your team. So I think there's lots of innovative ways for us to reduce the amount of people in one space through optimization of care, communication, but also not limiting families and putting them first. Really, I think we have to pause and think about how we can do things differently.
We're at noon now, and there are many other questions, which is delightful because there's a lot of interest on the line. Would you folks be open to, if I share the questions with you, responding to them, and we'll post them on the website where the recording of the webinar will be posted?
Absolutely.
Absolutely.
Wonderful. So that's the end of our time together then today. I want to thank you, Fabiana, Marcia, and Carol, for sharing your time and expertise with us. It's been a fascinating discussion. Thank you to all our members and other attendees for choosing to join us. We know how busy you are right now, and we hope you depart with some practical knowledge to bring back to your organization. Join us on May 5th at 11 a.m. Eastern, when we're pleased to partner with Solutions for Kids in Pain, or SKIP, to bring you Comfort in Pediatric Critical Care, a challenging new priority in management of pediatric critical illness. We also invite you to save the date for our 2021 annual conference, taking place virtually from November 22nd to 26th in 2021. The theme this year is From Crisis to Catalyst, the next chapter for children's healthcare. And the call for abstracts is now open. Feel free to submit. It's also always great if you watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thanks to Fabiana, Marcia, and Carol, and for this presentation. And hopefully we'll see many of you back here on May 5th. Bye, everyone.